So, for those of you who don't know me, my name is Megan Robarczyk. I am currently the Global EM Fellowship Director at the University of Pennsylvania. I'm an assistant professor of clinical emergency medicine there as well too. I am a scholar in our Center for Global Health through the Perelman School of Medicine. I'm also a senior scholar in our Penn Injury Science Center as well too. It is a pleasure to be with you all today. I'm really honored by the opportunity to talk for this fellowship series. It's my first time doing so. And I want this to be a discussion. So today we're going to be talking about global health equity. So this is a huge topic, much more than we could talk about in the next hour. And there's so many different subtopics within it as well too. And as I'll talk about in this first part, we're still very imperfect about in the language that we use and the way we talk about it. So please feel free to stop me at any point, especially if I'm not getting something correct. I want this to be a discussion. I want people to chime in. So feel free to use the chat box. I'll be monitoring that. Unmute yourself. I want this to be a discussion because that's really what it is right now when we're talking about this topic in general. So please feel free to stop me at any point. But I do have a few slides that we can go through just for some things to kind of guide us in that discussion. So I'll do that and then we'll go forward from there. Before I get started, anyone have any questions or anything they want to bring up? All right, if not, let's jump right in. So again, the topic today is global health equity or global emergency care equity. We're going to kind of touch on both. And to start off with, I don't have any disclosures except for the fact that obviously you can see I am a Caucasian woman. I'm at the University of Pennsylvania in the United States. I am in a high resource setting, in an EM robust setting. So we could basically stop the talk here and just, talk about that and, talk about how this topic has really been at least spearheaded from the sides of, the high resource settings, EM robust settings, all of that. So we're going to go into that a little bit, but yeah, my only disclosure obviously in this talk so far is basically that. All right. And again, too, this is better really as a discussion. So I do hope that you take the limitations of my perspective in presenting these few slides of the language that we have in general surrounding this topic. And I hope it spurs some additional discourse within this first hour. But then as I drop off and you guys have a discussion amongst yourselves or even going forward from here, I hope you have a longer conversation about this because this is a conversation in process and hopefully beyond conversation into action as well too going forward. So at least for the first part of this, during this session, I'm hoping that we're going to review a little bit of the history of global health because I think we can't really talk about where we're going if we don't talk about where we've been and kind of the colonial shadow that weighs in a lot of this. And so we really need to talk about the history first and really own the history before we kind of get into where we're at and where we're going to be going. So we'll start with that. So hopefully this will give you a bit of review of that, which you've probably had in many of your courses so far throughout fellowship and otherwise, but hopefully we'll kind of condense it down and maybe go into some aspects in terms of the history of emergency medicine. I hope that you all have a chance to understand some of the important components and considerations when we're talking about global health equity as this topic. And then we're going to explore some methods for engaging in the field of global emergency care with a particular focus on equity as well too. All right, so let's start first with the history. To start with the history, we really need to just define what we mean by global health. So again, like I said, I want this to be a bit interactive. So what is global health? How would you all define global health? Throw out some definitions for me, either in the chat box or feel free to unmute yourself or raise your hands as well too. I can call on people either way. Again, I want this to be a discussion, pretty informal. I want people to get engaged. So throw out some definitions for me. Perfect. I like this one. State of well-being and quality of life for all persons across the globe as it's affected by socioeconomic status, geopolitical changes. Great. That's a good one. Any others? And you don't have to give a full definition. What are just some components when we're talking about a definition of global health? Like what are some of the components that we think are essential for the definition? I think we'll stick with this one for now, but this is the one that I tend to like, and I'm sure you've all seen this. This is the Copeland definition that was proposed in the Lancet in 2009. The complete definition among this, so I've just kind of paraphrased it here, but the complete definition that's in that is global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So global health emphasizes transnational health issues, determinants, and solutions. It involves many disciplines within and beyond the health sciences and promotes interdisciplinary collaboration. And it's a synthesis of population-based prevention with individual level clinical care. So I think, at least to me, this is probably one of the best and most comprehensive definitions I've seen to date. There are many other definitions that do exist. However, most do tend to have these common characteristics, such as what was proposed by Brittany in the chat. But the common characteristics of number one, equity, which is a reason why we're talking about this today, this global conceptualization, so all persons across the globe, thinking about things from a variety of aspects, such as causes, means, and solutions. So, kind of from beginning to end, comprehensively. Also, a multidisciplinary approach. So, just beyond medicine as well, too. We're not just thinking about medicine. We're thinking about geopolitical changes. We're thinking about socioeconomic status. So, I like how those were mentioned. And then, multidisciplinary. It's not just medicine. We have to think about, engineering and infrastructure and law and policy and all of that. The other definitions also do conclude like including consideration of all action of all actors, mutual accountability as well too. And then both reactive as well as proactive approaches. We're thinking about like prevention and all of that as well. So I think, at least to me, this is probably one of the most, this one by Copeland kind of includes all that and is one of the most comprehensive to date. But I want to highlight that even back in 2009, so this conversation about decolonizing global health, as we'll talk about, it was initially proposed, but now talking about global health equity was proposed in this definition back in 2009. And even before that as well too, but we really haven't gotten to fulfill this definition yet. And the reason for that is really the history and really what has led us to where we are today in terms of when we think about the history of global health and all that. So let's talk just a little bit more about that and see why we're not quite fulfilling this definition yet, and then how we can really move forward in practical ways to fulfill this definition. So the history. As the way we do things now, even though it's not perfect, isn't the way it was always approached. So back when in the very first origins of global health, it really had its origins in what we would call tropical medicine. And that was really founded very deeply in colonialism. We're talking about military medicine, medical missions, where people were really focused on communicable diseases and how could we prevent these in our explorers, in our colonizers, in our militaries as we go out and we, conquer different peoples throughout the world. And the language at that time was very focused on this as well too. It was all like as we talk about how people approach this from the mindset, it was really to quote westernize populations, to convert populations to Christianity, to really selfishly protect the colonists, the militaries, and all of that. And even in looking at the language associated with this with the London School of Tropical Medicine and Hygiene is the full name of that. There was a lot of this language that focused on terminology that was very biased and very inequitable in terms of that. So this was really up until about the 1800s or so. There were forced inoculations. This is a picture of a collar inoculation in Calcutta in 1894 down at the bottom. So again, really the origins of this was tropical medicine and is very rooted in colonialism. And unfortunately, we haven't shed that completely today. But as we go along in our history, we begin to kind of in the late 1800s, early 1900s, mid to mid 1900s, really think about this concept of international health. So, at some point, these large empires begin to break down. You form new borders. Equitably or inequitably in most cases. And so there's this focus on international or work across borders. And so the terminology then becomes really international health. In 1851, the International Sanitary Convention, that was one of the first times people really came together to draft some international health policy, but unfortunately nothing was agreed upon. As you can even see from the name, just, the use of the word sanitary, just how we still think about this or how they were thinking about this at the time was very inequitable when we think about it. Later on in the 1800s, we have the formation of the International Committee of the Red Cross, which is now a part of the International Red Cross and Red Crescent movement, along with the International Federation of the Red Cross and Red Crescent Societies and National Societies. So we begin to get these larger organizations that begin to really think about health across borders and across populations a little bit more comprehensively. And we see some international collaborations as well too because of that. And obviously these were all affected by major events in the US, throughout the world. You've got World War I, World War II, there's cholera epidemics, yellow fever in the Americas, the 1918 flu pandemic. So all this really started to get people to really think about how do we think about health more worldwide. But again, too, like I said, a lot of these conventions and organizations still use the words things like sanitary and hygiene and things that were still really focused on, quote, civilization or civilizing different populations and whatnot, and still very biased. And even with the start of the UN, the development of the World Bank, IMF, the WHO in the 1940s, this was still very much the focus. So all these groups that were started kind of in the early 1900s kind of merged together to develop that. So in 1944, you have the Bretton Woods Conference in New Hampshire, which first came the financial institutions, the World Bank and the IMF, out from the UN, and then the development of the WHO after that, where it was really trying to merge these groups together and how could we change the focus and all of that. And then in the 1970s, we have Alma Ata, where the WHO and UNICEF led the International Conference on primary health care, where it really redefined what health was, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So I think this is where we really had finally that change in mindset. So we're trying to kind of adjust, at least in the makeup of all these organizations in developing the WHO, adjust it fundamentally in the structure of it. But then we didn't really start to have, I think, a change in mindset on what looking at health like this actually meant until then. And so this was great. We stopped really focusing on kind of those communicable diseases that were really, affecting, the colonizers and the military and all that kind of stuff. And we were thinking about how it's a fundamental human right and how it's a state of complete physical, mental, and social well-being. So not just physical, but mental and social, and then not just purely focused on like the absence of disease or infirmary. So this was a great big step in terms of really changing the mindset on what global health now is. Unfortunately, or then as a result of that, you have then the rise really of international NGOs and all of that. And so after that, people kind of, took that as a mandate to really attack health from a different perspective. But, unfortunately, it was, the right idea, but there was really poor execution, at least initially, in this, in terms of thinking about primary healthcare. There was still selective primary healthcare. There were still imperialistic policies by the World Bank, by IMF. As we know, many well-being, like many international NGOs have a lot of, like intentions behind them, but there's still kind of inequitable application of this idea and how to go about applying it to improving healthcare outcomes worldwide. And so even in the US, like love these organizations like, the Bill and Melinda Gates Foundation, PEPFAR, but they're still very focused on very specific things. So the Gates Foundation kind of very focused still on like malaria, that kind of thing. PEPFAR, they're still very siloed into like specific disease processes, trying to, of course, approach them more comprehensively from, multidisciplinary approach and all that, but still very limited sometimes in their scope. And so, at least though from the 1990s to present, we do change the terminology from international health to global health. In the 2000s, we start to think about this even more, like with the Millennium Development Goals. In 2005, they really start to reassess like how we are approaching this. So the Paris Declaration on Aid Effectiveness, all this money and aid that is being poured into these organizations and these NGOs and international NGOs that are approaching this, like why is it still not having an effect? And there was more than 100 countries that came together for that with the goal, in about 5 years after that to have, better alignment in terms of priorities, better relationships between donors and recipients, ownership, harmonization, managing for results, mutual accountability. And then in 2016, we have the development of the Sustainable Development Goals as well too, that has a deadline for 2030. And so, we're seeing little bits of progress throughout this time in terms of interconnectedness, thinking about multidisciplinary approaches like focusing on education, the economy, planetary health as well too. But there still is quite a bit of, threads of these ideas of like charity and saviorism and colonialism and all of that with it. And so we're getting there. We've made a lot of progress from the times of tropical medicine back in the 1800s up until now. But over the last few years, we've seen a lot more conversation about what global health is, and especially from the lens of global health equity. And so we'll talk about that in just a second, kind of where we're at today in terms of this conversation. Before we do that, though, just to take one more step back and to focus just a little bit on emergency care and where that fits into all this. So as we know, a lot younger of a specialty than a lot of other specialties. EM in the US came out in the 1970s as a specialty, first recognized as a specialty then. In 1976, we have the World Association for Disaster and Emergency Medicine that was found. The first ISEM conference was then in 1986. You have the development of the International Federation for Emergency Medicine in the 1990s. In the US, you see global EM fellowships for the first time really focused on this and how we can really focus on the global aspect of emergency medicine more in the 1990s. And then in the 2000s, you're starting to see the development of WHO initiatives really strongly in terms of emergency care and emergency care systems. So in 2007, kind of one of the first World Health Assembly items, the 60.22, which is health systems, seeing how emergency care systems are essential for those. Just to throw in some kind of more specific things, like in 2011, SAM developed GMA. We have the development of the Global Emergency Medicine Fellowship Consortium in 2012. And then you really start to see more of a focus on emergency care in kind of the larger environment, especially when we're thinking about policy and funding in kind of the mid 20 teens and on. So from 2015 to 2018, in the Disease Control Priorities 3 version, you see a chapter on emergency care. In 2019, Fogarty starts to develop more opportunities in terms of research and all that. So the Collaborative for Enhancing Emergency Care Research was developed, or CLEAR. And then in the last like 5 years or so, you see a huge rise in the number of initiatives being passed through the World Health Assembly. So 2019, the really exciting one on emergency care systems for universal health coverage and how important that is. 2023, integrated emergency critical and operative care for universal health coverage and protection from health emergencies. And just earlier this year, then the next step, development of a global strategy and action plan for integrated emergency critical and operative care. And so as you can see, really a lot more focus on emergency care. And I think emergency care and emergency medicine are really kind of leading the way in changing this conversation on how do we think about this kind of work and improving health globally in an equitable way. And I think it's a great time for all these initiatives to be coming together on the international stage for emergency care, because we're also having these conversations about global health equity, and they can be included in at the same time. And we can start these initiatives from the right place rather than having to, take what's happened throughout history and kind of trying to change that conversation from there. So, really exciting time. Even to beyond this, there were lots of advances in humanitarian response. When we think about like the first humanitarian charter in the 1990s, the sphere standards that came out in 2000 as well too, kind of the development of the UN OCHA like cluster system, just really trying to focus a lot more on accountability, equity, and how do we do this work better in a better way, in a more equitable way. So, in kind of summarizing where we've come from and where we are now, we just started with an initial focus on like in those individual disease processes, communicable diseases, and we're now thinking about systemic change more often. And instead of to this kind of head of the table, boardroom table, and equitable way of bringing partners and working with partners on this stage, we're now transitioning to think about this more as a roundtable and a discussion and a way of approaching this, hopefully, as we really engage in these initiatives in global emergency care that the WHO is merely mandating in this more equitable way. But to do that, we really need to think about what do we mean when we think about doing this in an equitable way? What do we mean when we talk about global health equity? And so how can we really change the way this conversation happens, change the way this work happens, and start from point one and take it forward from there, but also still being mindful that unfortunately there is this history. Like even though, emergency care was only developed in the 1970s, we do have those origins in tropical medicine and international health and all of that. And so unfortunately there is going to be, no matter how well we try to start the conversation now or continue the conversation, there's going to be this element of, neocolonialism. There's always going to be a power differential, at least for now, maybe, but hopefully not. And hopefully we can change that. And like I said, start some of these initiatives from a better perspective and really design to align rather than, trying to be fixing things or coming at this from a different perspective of afterwards. So how do we truly begin to change this? It really does start with the fundamentals and how we engage in the work. And so let's talk about some of the fundamentals first about when we talk about global health equity, what are some of the components that we need to consider? So first of all, what is it? So more recently, we've had this initiative of decolonizing global health, and even with that, we realized with approaching the initiative from that perspective, even naming it that way was still a way of not thinking about it correctly. And so I think in most groups that I've been involved with more recently in talking about this, we've started to talk about it as global health equity. As you can see, this was a slide that one of my colleagues sent on one of the chats that I'm at about what is decolonizing global health. And so I thought this was great in terms of really just thinking about some of the language that we use, the terminology that we use, and how limited it can be. And even though we think we're coming about it from a correct perspective, how can we even re-examine some of the things that we're doing and how we're talking about it and start off on a better foot? So I love this slide where it says the colonizers invented the concept and the name colonization, and now they have invented decolonization. We don't want you to come fix the problems that you created. We just want to be treated as equal partners and work together to solve global health challenges. So again, just bring everybody to that round table to be able to have a conversation. So if we're going to try to define what we mean when we talk about this and trying to focus on global health equity, again, just like the definition of global health, there's many different ways that you can define it. I think one of the best ways that I've seen so far is that it's a fair and just opportunity to be as healthy as possible, or for people to attain their full potential for health and being, and that people have access to essential health services regardless of where they live, their socioeconomic status, their personal characteristics. Other people have defined it as like focusing on no large differences in health outcomes. But again, a lot of these are still very vague. So what does that actually mean? A fair and just opportunity to be as healthy as possible to attain full potential. But what does that mean when you inherently start at different levels? You know, what is someone's full potential in the United States versus their full potential in a resource denied setting? Those benchmarks are going to be very different. And so is it equitable that, the person in the US reaches their full potential and that person reaches their full potential? As you can see, there's still on two different levels. So what does that actually mean? And then what are essential health services? What are, essential health services in the US versus a resource denied setting? And so, I think we need to continue to work on this definition and what we mean and take it one step further. We need to actually define what those things mean. Is it a certain level of clean water, everywhere? Is it, these certain health outcomes that have the same benchmarks everywhere? Does it mean, are we focusing when we think about health equity and are we thinking about just the outcomes and those sort of things? Or are we just talking about too how we approach this? Like, are we thinking about like how the partnerships develop, how the projects develop, all of that? So, it's not just about health outcomes, but how we approach partnerships, mutual respect, how we approach like the structural determinants of health as well too. So, it's this is still going to be a discussion. The terminology might even change on how we're talking about this concept in the next few years. It was decolonizing global health, now it's global health equity. What's it going to be next? But I think, just starting the conversation about some of these concepts that we mean is the first place to start. And then even if we're not able to talk about it, there's still some limitations in language. Like how can we actually put this into practice? How can we model what we mean? Sometimes it's easier to do things rather than to get really focused as much on the terminology. The terminology is absolutely important. I don't want to gloss over that, but we also need to at some point start doing things as well too, and that's where it comes from, this idea of approaching things from mutual respect, humility, and coming to a round table and having those discussions as well too. And then how can we work on, designing and doing what we're doing in a way that aligns with what we're meaning to say and meaning to do and all of that on an equitable level. And so, again, kind of the first step in this, and these are some of the aspects that we're talking about, is just cultural humility and respect. So, step one is just recognizing those power structures and the neocolonialism that is unfortunately present. And so, really naming that, owning that, recognizing it, and then doing our best to talk about it and to address, and start wherever we're starting a partnership with, project with, from what we understand about those power structures and moving forward from there, and eliminating them as much as possible. But again, owning them, not glossing over them, any of that. Also recognizing with cultural humility and respect that it's not, so a lot of people talk about this as cultural competency. We've seen this when we're looking at people designing like global health curricula and fellowships and all that. And there's always a checkbox like, do you talk about global or cultural competency in your program and all that? And it's not. And, the next step is recognizing this is not a competence or a skill set. This is just like, teaching people to be human, to understand that there is like a variety of cultures, diversity, everything out there. And it's having that humility and that humility to understand that you don't know everything, that you don't understand everything, that your way of coming about things is not the only way, the best way of doing things, and having mutual respect. It's basically teaching people to be human, which is a really, hard thing to teach or hard thing to like get people to recognize, unfortunately, in this day and age. And so it's having this conversation and understanding that, to have opportunity to self-reflect, to understand your own personal biases, your weaknesses, your strengths, and coming into partnership, into a conversation, into a project where there are many people with diversity of cultures, with backgrounds, with competencies and skill sets of their own in terms of like actual skills and knowledge, and coming at that from that round table perspective. And so, this is really tough if you're someone who is like teaching or leading a program somewhere, like in terms of teaching learners and teaching people in global health, because it's really hard to have language to talk about this because it's really changing people's mindsets and attitude, and like I said, just teaching people to be human. And so I think this is, at least the first step in this is just recognizing all of this. And so I think there was a Scientific American article that came out, I think, in the last couple of years that talked about like it was a conversation with some global health experts throughout the world, and it was what gives you hope for health equity. And it was kind of approaching it from this, like, this, like, people talking about, like, coming at this from the human aspect of things, and the fact that still is, present. And I think in some cases it's been almost lost, but at least dialed down. And I think, as we approach this again, we need to really re-examine this. And this needs to be the first step when we come into this sort of work and think about it from this way before we start with anything else. But like I said, it's difficult to do with imperfect language. When we're talking about like a diversity in cultures and backgrounds and everything, it's really hard to talk about this and like to define some of these things that we're talking about, like defining global health equity. How do we do that? And then how do we even like begin to have a conversation if the language itself is very limited? And I think part of this too is, just even thinking about examining how we communicate and how we talk. So when we're thinking about, as we're having these conversations, like think about the language that's being used, both written and spoken. Obviously, there's a lot of times that this happens in English. We're doing this talk today in English. There's lots of limitations to English and how we talk about this. And then just in terms of communicating with people in different partnerships and throughout the world, using English, using other languages as well too. When we're trying to talk about this stuff, being very mindful of again, those power imbalances. And again, just approach this from the perspective of being human. Really try to avoid dehumanizing, derogatory, and patronizing terminology. Again, it's really sometimes tough to do this. Our language, the English language, as we're using right now, is very limited in this. And again, it comes from kind of that colonial perspective where a lot of this language is inherently has that in it, that shadow in it. And so how do we try to at least if we don't have any other terminology, how can we acknowledge that and change that conversation and then maybe try to approach different terminology when we're talking about it? And be very careful too, just in terms of like nonverbal communications when we're talking about pictures, branding. This is becomes really important when we're talking about like doing projects with partnerships and we're posting things on social media, when we're posting things, on academic websites or things like that. And so be very mindful of those things as we're engaging in this type of work, and be very mindful too of consent. So just kind of one thing to kind of provide an example of this is from the American Academy of Pediatrics GHERD curriculum. This is a word soup activity that they do. And this just trying to highlight some of these things that we talk about and how there can be inherently some power imbalances. There can be some connotations involved in some of this language and how we're trying to work on changing that, at least in the language, English language, when we talk about this kind of stuff. So, equality versus equity. And we're talking about like first world, third world versus high income, income countries, or the terminology that's kind of encompasses this is a little bit better nowadays. So resource limited versus resource denied. So kind of another way of putting this is like when we're talking about emergency medicine, developed EM or underdeveloped EM to EM robust or EM nascent. So trying to avoid some of these like more negative connotations, the kind of neocolonial influences that come in some of the language, and then really perpetuate those power differential and power imbalances, and doesn't really recognize some of those things that have happened in the past that have resulted in things being the way they are. So for example, using the word resource denied rather than resource limited. So yeah, that's one way of doing it. One other thing I wanted to highlight was just that nonverbal language and how we use pictures in talking about or in this type of work. And I want to just show some examples of some pictures that have been used in the past. At least one or more of these you might have seen before, and just the different things that they can trigger and that they can highlight in terms of the inequities when we're talking about nonverbal. So just want to kind of give you a caveat right before we change to this other slide that these photos kind of evoke very strong emotions and things like that. But I just wanted to show them as well too, to kind of for us to be very mindful about how we think about like nonverbal communication in this type of work as well too, and in taking pictures and all that kind of stuff. So people talk about the pornography of poverty, pictures that capture things like volunteerism, white saviorism, all of that. And so I just want you to keep that in mind too. So really need to think about, acknowledge and critically think about the impact of, not only the verbal language, but the nonverbal language that we have, minimize colonial influences, promote equity, think about creating, ways that we can do better in terms of this. So another aspect to think about is partnerships. So in partnerships, really thinking about mutual respect, shared decision making, transparency, sustainability, bilateral capacity building. So this is that first word in that, bilateral, is the one that people really don't think about as much. We're thinking about like global health experiences in sending people abroad, bringing people to the US in terms of the work that we do. So it really needs to be bilateral. And then also thinking about boundaries as well, to our own boundaries and our partners, boundaries, limitations as well too when we're thinking about partnerships, we're looking at them from an equitable standpoint. And this was a list that was just so for those of you who were at AFSEM most recently last week, this was talked about in the Global Health Partnerships talk as well too. Representation is another big area that we need to think about equity. So who is setting the agenda and priorities, who's setting standards, who controls and writes and directs MOUs when we're talking about partnerships and work. And then again, too, going back to the kind of those pictures, like how are partners portrayed, associations with different groups and historically different groups, and thinking about like saviorism and all of that. So ways to really think about a representation of different groups when we're thinking about partnerships and work and global health equity. Access and resources. A lot of this really hones in on like when we talk about like education experiences and global EM experiences, like short-term global health experiences or STEGs in global health for especially for learners. So who's teaching when we talk about this type of work? Like who really is best equipped to give a lecture on TB? It's definitely not me. I haven't seen that many cases of TB in my life. And then, talk to some of my partners abroad and this is like old hat. I was talking with some of my partners in Botswana at AFSEM when I was there, and we were talking about like ID cases and all of that. And they were talking about how boring it would be to give like a lecture on, complications of HIV. And I was like, yeah, we never see that. Like and all that. So when you think about like who's actually best equipped to give the lecture, like for example, this talk today that I'm giving, like who actually really is best to give this? It's definitely not me, but it's something that we need to think about more critically. Also, who learns, who's the target, as we're sending as we're sending, learners and trainees abroad, like who actually really needs to learn, who's the target, how can we make those more bilateral exchanges? Again, where like the short-term experiences in global health, and then how like when we think about inequities and internet access, all that kind of stuff. And then just more broadly, when we're thinking about global health, global emergency care in general, like, content of teaching, financing, how do we define what the essential resources are? What does equitable access mean? All of that. So these are, when we talk about access and resources, is a whole other talk that, or at least hours and hours of talk and things that we could, like each one of these could be their own talk in and of itself, but just some essential components to start thinking about as well too. Recognition and promotion more broadly. So authorship, there were some studies that came out recently that showed that only about 16% of manuscripts that were focused on resource denied settings actually had authors from those settings as well too. They were looking at a group of papers focused on Africa, where about a fifth of all of those papers had no African authors, and about 66% of all authors were not African among those. So we need to be thinking really about that when we're doing this type of work, especially too in terms of recognition, like awards, appointments, grants, advancement of partners everywhere. So promotion's not the same everywhere. I highlight this one paper that I was involved with here, where we were talking to our partners in Pakistan and about their promotion. None of them wanted to be last author at all, because for them, actually, in terms of their promotion, it's the first 6 authors in the list are the ones that get credit for promotion. And so it's really like having like just opening up and being curious, like having that humility of like understanding that you don't know everything. Like, we think that it's first and last author in our setting is what gets, all the credit and promotion and all that. But like having that humility to step back and say, what is it that you guys like? What does everyone in this group need? How can we make this as equitable as possible so that everyone gets what they need? And we need to do that. You need to understand the process and the setting and all of that in the context. And so being open enough to have those conversations and that humility to know that you don't know everything, or like things that you think are correct everywhere or not, and have those conversations to try to optimize it as best as possible to try to get people, you know, in at least when we're talking about recognition promotion in the way that they need to be. So having that is really important. All right. I know we've got about 15 minutes or so left to go. I just want to kind of highlight very quickly then some additional ways. So I've kind of talked about some abstract ideas here in terms of when we think about global health equity, some of the big kind of areas we need to be thinking about, such as, recognition and promotion. We need to think about the language that we use and to talk about it. We need to think about partnerships and how we approach those. But then, okay, so how do we try to actually put this into practice? I talked about modeling and I talked about, designing to align. Like, how do we actually now practically do this in emergency care? These are very abstract things. So let's talk about, ways that we can engage in more equitable global emergency care. And I'm going to break this down into just a few different areas that we all might engage with in various aspects, as we go throughout our careers. So one way that people engage, especially, people outside of this realm, the one that we work in, is just donations. So it's a great way to engage. It's a great way for us to even engage as well too, because there's not always times that we understand the context or we're able to engage in a partnership that is equitable, you know, just based on our time limitations, resource limitations, all that kind of stuff. So how can you otherwise engage? And donations are actually a really great way to engage. Just ensure that, that it's, local organizations, if at all possible. There's transparency, regardless if it's local, international, whatever, there's transparency in the way that funds are used. And so there's, a lot of different ways to get online and to, look at, the reports from different organizations, the executive reports every year, make sure that they're transparent on how funds are used. You can go to a bunch of different websites that, rate different organizations on how well they use their funds. And then really just educate yourself too on how funding has or has not been useful. As I mentioned in the history, when we talked about some of the larger international meetings that have happened in the past, kind of examining how aid is dispersed throughout the world. This is a huge area where, colonialism still exists. And so, educating yourself in this realm is a couple different examples of some books to read, but, trying to do your best in terms of researching organizations, donating to local organizations if at all possible that are very transparent in the way that they're using their funds. This can have a really big impact, especially if you're not able to donate kind of the time, the resources to be able to engage in the work directly in an equitable way. So invest in those who are doing that work in that way. Another way that we engage is obviously direct medical care. It's a really great way to engage as well too, but this is really tricky to do this as well because it's really tough to come into a situation and really understand the context very quickly to be able to provide good quality care in a new and very different setting than maybe what you're used to practicing in, also in a way that's accountable, that does not disrupt kind of the local standards of care and local mechanisms for care and the trust that local populations have in local providers as well. And then continuity of care too, unless you're planning on staying in a location for a long time and making it kind of a new place that you're living, kind of how do you transition that care then to local providers? So, it's a great way to have a positive impact and to teach and to learn and to have that bilateral exchange, but then also think about ways that you can then promote local providers in the work that they're doing, have a bilateral exchange if at all possible, and then, yeah, accountability and continuity. Because, it can be really challenging to do this work in locations that, are not the usual settings. So these are just some of the locations that I've practiced in the past, obviously very different from where I kind of currently practice at the University of Pennsylvania and stuff. And so this is something that you really need to keep in mind, or as you're training, learners in this space, as you go forward and train learners in this space, encourage them to really think about this critically as well too. So yeah, this is an example of, a pharmacy at one of the emergency departments that I worked in here in the bottom left. Obviously, kind of some clinic locations, emergency department locations at the top, and then an X-ray machine that intermittently was functional at a clinic as well in one of the areas that I worked. So again, think about it for the work that you're doing, but also as we think about going forward and teaching trainees how to do this work, being mindful about how we engage with them, how we teach them about how to do this work and the resources that are available, and then how to keep it accountable and ensure that there's continuity of care. And of course, obviously avoiding things like volunteerism, especially this is something that people are very prone to, and new learners are prone to be doing in this type of work. So there's ways to encourage people to engage in this work that other than going into a new setting. So obviously care of displaced populations and refugee health in the US. There are obviously very many low resource settings in the US. We are definitely not, as we all know, the perfect example of perfect healthcare in the world. And so there's a lot to do in terms of our own work and a lot to learn from partners in terms of improving our own healthcare in the US. So keep that in mind. Travel medicine as well too is another way of kind of engaging in global health. And then other ways on a day-to-day basis in the US, we can engage on this. So discharge instructions for people in different languages using different terminology that might be better suited to different populations, utilizing interpreter services, and more appropriately, waiting room resources as we think about social determinants of health, as well as kind of how we need to approach thinking about global health and global health equity from a multidisciplinary lens. Like how can we develop waiting room resources that, may have to do with health outcomes, but may like directly or may indirectly have to do with health outcomes. We're talking about community resources for education, housing, all of that kind of stuff, and then access to follow-up care as well too, which is really important when we're thinking about continuity of care and thinking about engaging people in the health system and not losing their trust in the health system as well. in this process. Another way that we all engage, or some of us engage in this work, is disaster and humanitarian response. This is like direct medical care, I would say, on steroids. This gets to be a lot harder when we think about global health equity, just because we're inherently in a very inequitable state at that time period. This is like the most vulnerable people can be after a disaster, after a complex humanitarian emergency. And so those power structures and power differentials are vastly exaggerated and vastly and are very apparent at that standpoint. And so, this is like the next level up in engaging this work. So you really need to approach this from a very mindful state and really ensure that you are prepared. There's coordination, there is good health equity lens in place as you go and engage in this work. So as we know, there's no shortage of humanitarian crises right now. So there's lots of virtual opportunity. These are just a few, to say the least. Lots of opportunity to engage in this. This is, again, to a whole nother conversation of itself. I have myself done a little bit of work in this area and some pictures from that, but this is definitely not my area of expertise. And I recognize that this is kind of one of those areas where you need to have kind of an expertise not only in thinking about global health equity, but also that ability to do direct medical care and do that in the most stressful of situations. But there are, a lot of ways to get involved in this work. A lot of good organizations out there. Again, with all of these, make sure you vet them. All of these kind of have varying reputations in terms of how they approach this work from the equity lens. And so making sure to do your homework ahead of time, vet organizations, talk to people who have been involved with them, and keep that in mind. But the good news is that people are really starting to think about this work from the equity lens, and we talk about like coordination and things like that. So as we all know, like in the last several years, we've had the development of the UN OCHA system, the cluster system, the sphere standards, to really try to think about this in a way that keeps people accountable and does the work in a sustainable way. In a way that then also thinks about transition afterwards, and then even beforehand too, like we think about emergency preparedness and response and all that. Research is another way to get involved. Just make sure we're thinking about local questions. So it's not questions that are being imposed on local populations. It's questions that are arising from problems that have been recognized in local contexts that are important to be solved in those contexts. And then there's accountability in terms of reporting back to local populations on the results. And then we talked about kind of in the promotions, recognition from that standpoint of things, making sure that's taken into account when we're thinking about global health equity. And thinking about this too, and just thinking about how we approach promoting this type of work, publicizing this type of work, doing this type of work. So you can do, your work as I have done. And you could see some of my things in the past where maybe we could have been a little bit more thoughtful about where we promote this type of work or publish this type of work. But AEM education training and also global health, at least if you're going to target those type of journals, are they at least open access? Obviously there's limitations, a lot in publishing this work in English most often, especially those of us doing this work here in the US, but are there ways to get them translated as well too, or into other settings that might be more accessible to partner populations as well too. So journals you might not think of, so like more local journals. So for example, I have the Pakistan Journal of Medical Sciences. Instead of, having your partners come to the US for things like SAM and ASEP, maybe think about USIM. That might be a more accessible conference to them, closer depending on the setting that they're in. Like if you have partners in Asia or Africa, like AFSEM that just happened this last week. So, don't think about always like the traditional journals in terms of global health and all of that, but how can this be more accessible to the populations and those who are more affected by the research as well too. Education, I think this is probably one of the best ways to get involved because I feel like it's a really easy way to really have a lot more of those bilateral exchanges, especially nowadays that people are doing things a lot more like virtually. And so really think about those partnerships though, making sure though that it's really a round table that people are coming to rather than, someone directing the educational work. Again, being mindful about who the learners are, who the teachers are, and making sure there's teamwork involved in that. So these are just some examples of some work that I had done in Pakistan with this. And this is where I'm biased and think that a lot of these conversations on global health equity can really happen in this context and where there can be a lot more of this, what we're trying to practice, put into practice, where you can really design to align goals and things like that and empower partners on both sides, and then also exchange ideas where, care on both sides can be improved as well too. So I know I'm coming up to time. I do want to leave a couple of time for a couple minutes for questions, but kind of summarizing everything we've talked about today. Unfortunately, global health and global emergency medicine, global emergency care have really long and inequitable histories, even though, again, EM kind of has come about more recently. We do have, unfortunately, that shadow of tropical medicine, international medicine, that has been in our remote past. And so it unfortunately still is persistent today in neocolonialism and the work that we do. And so we need to continue to work toward a practical and actionable definition of global health equity and practical and actionable work that we do when we engage in this type of setting in terms of equity modeling and designing to align to make sure that, even if we still have limited language and all of that, that we're able to at least start working in the space and working to improve it. So, language is limited. We need to start somewhere and keep in mind the inherent and structural inequalities and biases, and we really need to stay humble as we go. There's a lot of different ways to engage in this depending on your headspace, where you're at in this space, and your abilities to work in this space right now. So, like I said, anything from donations to humanitarian disaster response, but we need to start somewhere and to keep working. So, again, I hope you take the limitations of my perspective, the limitations in language that we have, and I'm sure all of the inaccuracies that I talked about today and the limited language that I used to talk about it today. But I hope this again spurs some additional talk and discourse and action going forward. So, really, thanks so much for listening today. I'd be happy to take any questions, just some additional resources as well too. I'll send the slides to Dr. Feltes to be able to send out, and I'm happy to take any questions. So, thanks so much.
Hey, thanks for the presentation. This is Juliet from UC Davis. I just had a quick question, as kind of this is a discussion that my fellowship director and I have when we try to prep our residents and our medical students for global experiences. Is there a certain language or certain examples that you're giving to prep either your fellows or residents when they are doing like a pre-trip departure to make sure that they're addressing equity as they're going over? And, we loosely use the term to just have them be normal people as they're over there. Do you have any examples?
Yeah, I think there's a lot of programs out there that are working in this. There's a few examples of like some free open access stuff online. So I generally like try to direct people toward the Practitioner's Guide to Global Health online course because it's free and open access, and at least starts that conversation and helps kind of prepare them and think about some of these topics, at least to start with, and have that be like the initial thing that they do before I meet with them. Be like, look, go through this course. Like there's going to be a lot of stuff in it. And then let's sit down and have like a conversation about some of this stuff. So then I think a lot of this too is like one-on-one meetings. Unfortunately, when we're talking about working in this space, that is a lot of time on whoever is doing the teaching and like the mentorship of folks going abroad. But I think that's what it's like, that's worth it. And that's what's really needed for folks working in this space, just because as you can probably see from this talk, this is not the best, having a talk and having slides is not the best way to really engage in this and like talk about it. And so, giving them some of these like online resources that are available. So that is one. That GHERD curriculum, trying to incorporate some of that and maybe some of the work that you do with, if you're doing it with a small group or a larger group, some of those exercises to get people started to think about that. And then having those like one-on-one mentorship meetings and really talk about like, okay, what are you doing? What do we think were your encounter? Like, or hopefully something about like the location that they're going to be working, to be able to have those conversations and then like going to go forward from there. So I think those are some of the ways to start. But again, there's lots of different examples of programs doing this out there and lots of different curricula out there. CUGH has like online curricula about like, unfortunately still using the word competencies, but like global health competencies, stuff like that, that at least gets the conversation started. And then depending on where your learners are at, you can start with one of those. But I think kind of one-on-one meetings are also a way to go.
Okay, thanks.
Awesome. Thanks guys for joining. Any other questions? All right. If not, like please feel free to reach out to me. My email address is there, and I will step off because I know you guys have a little bit of time now. It looks like only a couple people still left, but give you guys a chance to have a conversation as well too afterwards as fellows. So I'll sign off. Thank you guys so much.